Well, I am truly honored to be here with two esteemed policy experts in Washington State. The first is Dr. Fotinos, who serves as the State Medical and Behavioral Health Medical Director for the Washington State Healthcare Authority. She has a rich history working in the government administration industry and is experienced in program development, healthcare policy analysis, medical education, and medicine. Our next guest is Representative Riccelli. He serves as chair for the Healthcare and Wellness Committee in the Washington State House of Representatives. He's vice chaired the House Healthcare and Wellness Committee for 3 years prior to that, and served as Deputy Majority Whip since 2014 and Assistant Majority Whip in 2013. Please welcome our guests, our panelists. Great. Well, thank you all for being here. I'm excited to have you all here. First of all, Representative Riccelli, thank you for welcoming us into your district. I know a lot of us are excited to be here. So my first question is really about a look back, because I think oftentimes we spend our time focusing on what's coming up next. What do we have to do to improve things? But I think it's important that we also take a moment to really look back and talk about our successes and even the challenges we had and whether or not we did a good job facing them or if there were areas for improvement. We're about 10 years out from implementation of the Affordable Care Act. We're about to enter a brand new administration, governor administration, lots of changes coming up in general for Washington State. And I'd just love to hear your all's thoughts on where you feel like Washington has been in the last 10 years, and what do you feel like we've done well, and what do you think we can learn?
Well, first, thank you all for being here and trying to dive deep into the policy interventions and on the horizon that can actually make real change. You're in the 3rd district, and just for those of you who are not here, just a reminder, we have some of the most impoverished folks in our state and a couple of census tracts around here. And so the challenges that you are tackling and the legislature is trying to tackle are the things that are really trying to improve the overall wellness. But it's particularly close to me in this district where we do have a lot of people that are struggling. So the look back, I think there's a lot of good things that have come. I mean, obviously the Affordable Care Act and providing more access to more folks has been really significant, but that can't be, without the discussion of what I think is a good look ahead that the federal government's doing. And I believe we're trying to steer at the state to say that, it's not just great to have a health insurance card. You have to have access to care. And I think that whether it be primary care access or behavioral health care access, that's kind of the next step. Some of the things I think we've done well to help, and I've been pleased to work on. I think we have embraced telehealth in a way that, particularly with behavioral health, has been a tool. We were working on that prior to the pandemic, but it set us up so that we were able to, I think, navigate some of that. I think particularly pleased how we have worked to try and expand oral health access and bring that into the conversation in a way that it hasn't prior been. You all are public health folks. You all have been talking about it, but you know how sometimes it takes a while for the policymakers and other folks to wake up to the importance of these things. So I've been very pleased about that. I don't know. Looking back, I think we have to look back at the pandemic as a major mile marker. And I think, we did really well to keep a lot of our citizens healthy and safe. But I'm pleased that we also have in statute, through the Public Health Advisory Board, some work going on to kind of evaluate, through my work on that board. We did a lot of things well, but I think there was some missing folks in our community that hopefully going forward, we're not going to have those gaps in understanding the importance of trusted messengers and how we work to make sure all folks have access and have the opportunity to be healthy and thrive. So that's a little bit on where we're at.
Great. Thank you.
Good afternoon. Thanks for hosting. And it's nice to be over in this part of the state. I think that we've done a number of things. I would add to the work we did during the pandemic. I think we've made the legislature and governor's office made substantial investments in behavioral health. Arguably, there are still gaps to fill. There are a lot of problems, but there have been significant acknowledgement and investments in that area. I think the other piece is the creation of version 2 of the Medicaid transformation waiver, and really the what we're seeing is the, I would argue, evolution of the accountable communities of health, and really their close working relationship with community-based agencies and organizations and public health and the healthcare system, which is not to say they're done and we're finished and we figured it out. We've not, but that those are sort of the seeds of an infrastructure that can continue to be leveraged to better bring whole person health to folks who need it where they need it. I think if I put my primary care sort of medical hat on, we have a cure for hepatitis C that is 1 pill a day. That's happened in the last 10 years, and the state's figured out how to pay for it for everybody on Medicaid. That's pretty cool. We have a medication for opiate use disorder that you don't have to go to a methadone clinic for every day for the rest of your life to get. Not enough people are prescribing it, not enough people are getting it, but it's available and it works. We have, drugs that cure sickle cell disease. Arguably way too expensive. That's a separate conversation. So we are making strides. That said, the other thing I would say I've noticed over the last 10 years is we're talking about equity. It's part of the conversation. We're not doing nearly enough to bring the right people to the table to have the conversations to tell us what we have to do and how we have to do to live that path. But I do think that's a conversation we weren't having 10 years ago. And the fact that we're talking about substance use disorders with compassion and humility about the people who use drugs, that didn't happen 10 years ago. So yes, there are a ton of things that we have to do, and we've got major gaps to fill. But I've seen progress in a lot of areas, and I would say in part just in how we talk about things. And the number of people raising the issues and talking about them is a lot more than it was 10 years ago.
Yeah. I think for policy advocates, I think you often think about how slow change is. And I'm sure you all hear that a lot as government officials. But we have made progress. And I'm curious what you would attribute to the success. What do you think Washington did? I mean, I've been doing these conversations across the country, and for a lot of states, they're just now discovering the Medicaid transformation waiver. But Washington's been doing this for quite some time. What do you think what would you attribute to those successes?
We're nice people. I think, I think we work well together. I think that, we will be having a gubernatorial change. We have a governor's office and a legislature that cares about the people that they represent. And that's a good starting place for a conversation, even if you don't agree to the how. The what's pretty simple. We want people to be well and healthy. And so I think there aren't fights about that. So I think having good relationships, both with our sister agencies from a healthcare authority perspective, we work well with our sister agencies. I think we have open and frank conversations with our legislators. Our governor's office has been very supportive, and we have had arguably really good support from, the federal government, current administration, in really recognizing that health is more about, there's more to health than medical care. And I think that's been transformational in how we talk about and think about bringing services to people. So I think it's really partnerships and conversation, and really starting from a place of, people deserve the ability to thrive and do well and be happy. So if we can start with that, at least we can have a conversation. We may not agree, but it's a starting point. I think that's part of it.
Yeah. What about you, Representative?
Well, I think, we have a citizen legislature. I think one of the things we recognize is our limitations, right? Half the time, my ranking member, Schmick, and I go into a room and we say, you all know way more than all of us. And so I think we've done a good job in Washington about embracing the folks that actually are doing the work and having them influence the policy. Obviously, I don't know if Representative Callan's here, but I know she was earlier, but she's in the back. Things like the children's mental health work. I've worked on a dental one table, where we bring in the folks who can help come to consensus and put forward policy. And then, the other thing is, the bottom line is we can pass all kinds of different policies, but a budget is a reflection of our values as a state and where we invest. And so being the way that folks have been able to advocate for these transformational investments is really important. And one of them was something that I came to, and I was on the healthcare committee for 12 years, but I really did not understand anything about foundational public health till probably 6 years into so the education has come on, but that's an area where, we realized, unfortunately with the pandemic, we had, weakened our front line of defense, but we have worked really hard collectively to put the kind of investments in that we need. And that was, again, sometimes it's understanding that you're working with the citizen legislature. It's got to be extremely frustrating at times. We turn over, the House turns over a third every 2 years. There's a lot of turnover coming on right now. And so we rely on that support and that education. Might seem like you're having the same conversations like Groundhog's Day over and over for a lot of this stuff, but it does matter. And I'm living proof that it works because, again, on a couple of these issues, I've been programmed. All health starts with oral health. That's my opinion. Foundation of Public Health, I had a lack of knowledge. And by the time I was chair of the committee, I felt at least like I knew enough to be able to influence and carry the message that were given to me.
You hear that, folks? He's trainable. So feel free to grab him later and train him on your issue. So we are about to enter another round of the Medicaid transformation waiver. And I'm curious if you, Dr. Fotinos, especially could talk a little bit about that waiver. What are we doing this time around? What are some of the key aspects?
I think there are a couple things that are continuing, but I'll start with sort of the new things that are priorities both for our agency and I know for the communities. And the two biggest right now that we're going to be implementing going forward in the near term are reentry services. And that will allow for people who are in prisons that starting 90 days before their release date, they will be eligible for a certain set of Medicaid services to be paid for in a carceral setting. That's not happened before. We're the second state after California to have that happen. And for people who are in jails, the average length of stay in jails for the most part is 8 days or less. And so what that will allow is us to continue coverage for people while they're in jail so that their Medicaid isn't turned off and that core set of services will be able to be reimbursed by Medicaid while folks are in jail. And there are 3 essential requirements that any jail who participates has to have, and that's that they need to be able to assess and treat people for opiate use disorder with medications and alcohol use disorder with medications. They need to be able to provide sort of case management to sort of assess the needs of that person and have a plan for them to follow up after they're released. And they have to provide 30 days of medication. There are sort of a second tier of services that can also be provided, but that isn't necessary for folks to start. We have lots of interest from jails, and we hope to have the first jails start to be able to bill and participate in these waiver services next July. It's a huge lift because what that means is, and anybody who's from a community-based organization or agency or small provider knows, credentialing with managed care plans is a challenge. Enrolling with Medicaid is a challenge. Billing across all those things is a challenge. So these are all the things that we have to be able to provide support, work with our managed care partners on helping to provide the technical assistance and support to these facilities to be able to do this. All of them are providing some level of health care now, but not necessarily that will be required to meet the requirements of the waiver. The other thing that is not optional and is not part of our waiver is that starting January 1st, we will be required to deliver similar services to youth who are in juvenile rehabilitation centers. So it's optional to provide these services in juvenile detention. We will do that, but we will be required by federal law to provide screening diagnostic services to youth in juvenile detention. And so we're preparing and working with the different facilities across the state to be able to do that. So that's exciting. We recognize that the keys to the success of that will be to not disrupt things in communities that are working, and really to help provide sort of that connection piece between the time that someone's incarcerated to wherever they need to go next and the supports that they need to do that. And so we've got a lot of work to do. We've got a lot of engaged partners. The second piece, which kind of flows into that, are health-related social needs. And that is a list of services that are not traditionally eligible for payment by Medicaid. Those include things like medical respite that we had a session on earlier today, food, nutritious meals for people with chronic medical conditions, pantry stocking, housing supports. So a list of other services, contingency management. So a list of services that you wouldn't necessarily think are medical health care services, but directly impact and improve the health of people who are needing support in those areas. We will be starting, and a key partner in that for us will be the Accountable Communities of Health. They will be setting up and operating what are called community hubs, and they will act as a clearinghouse for folks who may be seeking services in the community. If they have Medicaid, they'll be able to refer those folks to that list of health-related social needs. So we're starting with standing up the Accountable Community of Health community health hubs. We will have probably some of the health-related social needs are going to take a while to implement. But we will start with medical respite. We're still waiting for some feedback and approvals from CMS on our final, things that we have to do to be ready. So we don't have a lot of details I can share, not because I'm being cagey, but just because we don't have formal approval. So really excited about the ability to use Medicaid funds to help support the social determinants of health and the health-related social needs. So we're very excited about that. We'll continue our foundational community supports. Some of the waiver dollars will be able to expand some of those services. Stabilization centers, concepts similar to some of the crisis intervention services you've had. So again, these are all things that have to be built out and probably a couple years down the road. But the reentry services and really helping support the Accountable Communities of Health to continue the work they're honestly already doing is really our top priorities.
I love that you brought up the ACHs. I actually started at HCA after grad school and worked as a policy analyst on the ACHs. And at that time, people didn't really know what they were, what we were going to do with them. And I think we've seen a lot of transitional work happen and a lot of lessons learned. I know there's a real prominent one out here in Spokane. I'm curious if you could talk, either of you, about what some of the work you've seen them do over the last few years?
Well, let me go back further. We had some of our navigators initially with the sign of the Affordable Care Act, we had some of the best numbers in the state. And so just getting people initially under the umbrella was extremely impressive. But I think, I'll give you an example. And I worked with them out here. How are we connecting with our Marshallese community out here, and just how we get navigators in that are of the community, from the community. I know that that's happening all over the state, but I think particularly understanding that and embracing that to really break down those barriers, language, cultural, all those types of things. And, it was a real miss, and in some ways for areas that didn't have that during the pandemic. It's great if a school district, I heard, a school district gives hotspots out to every single student, but they found out, only like 20% of them were turned on because people weren't working with the families that had those gaps. So, I think I'm very proud of the work to go into communities to build that trust, and a recognition too that trust sometimes comes not just by saying we're here to help, but like finding a community member that can be employed of the community, from the community, to have that trust, I think is vital and important.
Great, thank you. I would add to that. I think that what we're seeing, in each region's Accountable Community of Health operates differently. They certainly share similarities and missions. I don't know their words, but I think they are helping to provide sort of an infrastructure and glue. And one of the things that excites me most, I was in a conversation with some of our DOH colleagues, and the Department of Health and the local health jurisdictions stood up their Care Connect settings during the pandemic and worked really closely with Accountable Communities of Health to really leverage, vaccine, where we'll take the vaccine van there, we'll get food there, we'll do this here, and really sort of bringing to bear the resources that communities already have to better coordinate and address needs that no one organization or entity alone can do. And that's really exciting because it's okay, we've got these building blocks. How do we take the next step and really coordinate and do well together with them?
Yeah, and that's been my biggest concern, is that I think with extra resources over the last couple of years, we've even strengthened those connections to build them up, and that there won't be the sustainable, like, we'll just let all that work go away. And I know you all are probably thinking about that way more than I am, but that's really concerning to me, that we've been able to build this infrastructure up and not understand how we're going to sustain and maintain that is one of the things that I really think a lot about.
Well, both of you mentioned behavioral health a little while ago, and I'd love to talk about that for a second. I know it's a top priority for a lot of leaders in the state, and I'm curious what you all are seeing as some of the biggest new initiatives or ideas that are coming out. What are you expecting for the legislative session? Any insight to that?
I think, from the legislative session, we've, from a state agency perspective, we have been cautioned that the budget forecast is unclear. It's, we are not asking for new programs. That's not realistic. I think the next couple months will give us an idea of sort of the financial health of the state. That said, like I said, the legislature and governor's office have been very generous, and arguably for all of you who are providers, it's still not enough, but been generous in sort of looking at rates, raising rates, being, directing us and our other sister agencies to implement new programs. And I would say, I don't know yet. They haven't been up and running long enough to know what kind of difference they're making. I think key pieces to keep an eye on are 988. I think the mobile crisis response teams will have an impact. We heard a little bit about those in the last session. So I think there's some things that are up and running, but they just haven't had a chance to develop and let us know if it's enough. And the demand still continues. So how do we get more workforce? You can't grow workforce, but can we look at our models of care and leverage, people to their highest level of care, and then have folks that don't need to have 2, 4, 6, 8, $1 million year degrees do some of the work? And I think legislatures funded the behavioral health technicians. So I think there's a lot of good ideas, and we keep adding all these things, and they're not up enough yet to know, which is not to say let's stop, but I think there's a lot of activities and work in flight that hopefully will give us an idea of if we're on the right track.
Workforce. We can fund all the things that we want to do. If we don't have the people that are being treated with respect and paid fairly to do them, then we're going to be in a world of hurt. So, and we already are. The piece that I'm interested in is schools aren't schools anymore. They're community centers, and every kid should be able to get a free meal there, and everybody should be able to get counseling there. And we have to figure out how we blow the doors open for access at our schools. I got a high schooler now, a freshman. I got a middle schooler. The trauma, the things that young people are dealing with, we need interventions on site and access. And so that's, I think, something that there's a lot of interest and enthusiasm. How we navigate that, I think, can be different, and localized, but we have to have additional policies that work and funding that makes it able to come to fruition.
I'm going to open it up to the audience to ask questions. My colleague Heather is going to run around with a mic, so if you want to raise your hand if you have a question. But while she does that, I wanted to talk about the budget, because that's been brought up a couple of times. And I know that the forecast is not great. And I'm curious, what do you all think is the best way to approach the budget this year? I think a lot of people are worried about how will health equity be considered, because oftentimes equity issues are usually the first things cut. So I'd love to get some insight on that.
I think those days are gone. If you look at the makeups of, the legislature now, the first voices would not stand for that. And I think you have champions that, will bring the place to a screeching halt if we decide to try and move in a different direction. With that said, the shiny new penny days are over. Like, we got to stop. We can't we have a 2-year, budget cycle and a 4-year outlook, and we have, and it's, legislators, some of it, we have a lot to be blamed for. We come up with thousands of different programs that we want implemented, and times were good during the federal spigot being turned on. This is going to be a huge wake-up call. I personally haven't, I was a staffer during the last recession, but none of the members of recent within my tenure have experienced anything like I think we're going to be facing. So metrics is stuff that all of you are better at and geek out on. We have to do program evaluation and we have to look at what's working. I think one of the biggest concerns I had, and thank you to great agency staff and other staff, like with the opioid settlement dollars, you should have seen the lineup of ideas legislators had. And it's time that we have to be focused and strategic, and we have to see program evaluation for our maintenance level programs.
And I would add, we, in a sense, we're responsive. We were not going to make any program changes or decisions until we know what we have to do. And as I said, we sort of went forward with this budget cycle knowing that there wasn't going to be extra money, and what we have to do and change remains to be seen. So I think, we're prepared in that setting. And I would just offer a counterpoint, which is separate from the legislative cycle. But I was just reminding myself, people talk about, well, if we could pay this person more and that person more, and we absolutely have to recognize and pay people a living wage for work they do. Peers are important, community health work is important, doula is important, and we have to pay them wages with which they can live and thrive. That said, our healthcare system pays more per capita than any other country in the world by 4 times. Our life expectancies are shorter, and we pay 18% of our gross domestic product for healthcare. There is plenty of money in the system. It's just not necessarily directed in the right place. So I would offer to all of us, how do we start those conversations? There's plenty of money in healthcare, but it's not necessarily going to the people who would most benefit from it and the people taking care of them. So I think it's a both and. Yes, we have finite resources, but the pot is large, and the people who are benefiting from it aren't the folks who are in poor health necessarily. And the other thing, just food for thought, so far this year on the U.S. presidential election, $15 billion has been spent. That would solve a lot of issues. So I think, again, how do we, with all of our voices, help frame the conversation around health about, yes, certain pieces need more money, but it's less about printing more and more about how are we prioritizing and how are we as a system and society, funding things in a way that makes sense. And stuff is expensive and it costs a lot. It's all true. But again, how do we broaden our thinking to sort of bring those other perspectives in?
Thank you. Any questions from the audience? Oh, such a quiet group.
This must be between here and
ready to go home. That's right.
I know. I was going to say, and I see a table of nurses that I know have thoughts and questions. Okay, great. Well, I guess I'll move to another question that I have, which is one of the things that is becoming increasingly challenging is access to care. And that's particularly the case out here in our rural communities. We have seen a number of hospitals close or close wards of hospitals. Can you talk a little bit about what you think are some of the ways we can combat that, both from a legislative perspective or from, a voter perspective? Like, what should us as voters and folks that care about this issue do?
Well, I think, as the prime sponsor of a bill that created a second public medical school, that the thing we shouldn't be doing is closing family medicine residencies. That's a problem. We need to figure out what is our commitment as a state and as communities to primary care and going upstream. And I think, we need to invest more in what we think we prioritize. And there's ways to do that. There's taxes out there that might be the ways to do it. There's investments in new residency programs, but it's also looking at who's delivering care. So we, thanks to, I don't know if the medical association is here, and thanks to the medical association and PAs, they went through some long negotiation, and PAs are moving to collaborative practice in underserved and rural areas. We have to, we have to look at the scope of what folks can do and understand that more people are going to be having to engage in primary care and going upstream, because we're not going to out-doc our way into solving this primary care problem. So I think we have to be very creative, but we also have to put our money where our priorities are. And I think we could be doing a much better job as a state going upstream and investing in the things in the long-term way that will be successful to move us in that direction.
I think primary care, and I would add that's a big initiative right now of the Healthcare Authority. We have a primary care program going on. We have, I think, 8 payers and 7 large employers that have agreed onto it. It's a shared Medicaid, Medicare program, really meant to recognize that primary care is foundational to health. And as a family doc, that's near and dear to my heart. And we also need our nurse practitioner partners and our physician's assistant partners to fill out that primary care workforce. Whether, so I think we had a conversation this morning about birthing care access in rural hospitals. And one of the recommendations was, which I thought was great, was how do we get our rural OB providers? You need obstetricians, but you also need, family medicine nurse practitioners or family medicine docs who do OB in those settings. But how do we send them to a big city for a week so they can get, sort of retrained on all those complications that do happen, but may happen once every 2 years. And in the middle of the night, if that horrible complication that you haven't taken care of for 2 years happened in your birthing center where you have 65 deliveries a year, that's not a situation you nor your patient wants to be in. So are there creative ways in which we can help train and sort of, bolster the workforce who are, want to live in rural areas and want that? How do we leverage residency programs and our teaching programs? Do we need to think about differential ways in which to pay folks who are willing to go? We have the loan repayment programs that do that. So I think we have some things that we're doing, but really, as a system, sort of reprioritizing the focus from specialty care. My lungs hurt. I'm trouble. I don't breathe well today. I'm going to pulmonologist. Oh, I got a funky heart rate. I'm going to go to my cardiologist. Start with your family doc, right? We've sort of gotten out of that, and it's interesting. When I was in England training for my master's degree, they pay their doctors completely differently. Specialists make no money. The primary care docs make the money like specialists do. No one makes as much as our specialists. But in other countries, the primary care docs get paid way more than the specialists. They're more valued because they provide the bulk of the care, that care coordination. So I think, to your point, how do we sort of refocus on the fundamentals of healthcare? Most people can get the vast majority of their needs met in primary care. And when they can't, we absolutely have to have that access to specialty care, but we shouldn't start with specialty care because that just kind of incents sort of backwards financial structures.
Great. Thank you. Well, we are actually almost out of time. We have a big countdown clock right there. And I know people have to get to the airport, but I just want to thank you both so much for taking the time to share your insights, for being here with us, and all the work that you do on a regular basis to improve healthcare in Washington. Thank you.